Dr. Charles Atwood graduated from the University of Alabama School of Medicine in 1988, where he also completed his medical internship and residence. He then moved to the University of Pittsburgh to complete a pulmonary and critical care medicine fellowship and an additional year of sleep medicine training. He joined the Division of Pulmonary Allergy and Critical Care Medicine in 1995. Dr. Atwood was the director of the pulmonary section at the VA Pittsburgh Healthcare System from 1997 to 2003. He also co-founded and has been chief of the sleep laboratory at the VA PHS since 1996. In this role, he has fostered its growth to be one of the largest in the VA system. In July 2008, Dr. Atwood was appointed the Assistant Chief of Medicine at the VA PHS. Dr. Atwood's clinical interests are sleep medicine and general pulmonary medicine. He sees patients at the VA PHS and at the Comprehensive Lung Center at UPMC, working with all types of sleep disorders in his clinical work at both sites. In addition to sleep disorders, he is interested in the clinical management of lung nodules. He also leads a lung nodule evaluation program at the VA PHS. So Dr. Atwood is going to kind of speak to us about outcomes in portable monitoring, which kind of will tie a lot of this together. He's got a couple of talks. We'll have a break in between the two.
I have two presentations I'm going to give today. The first is measuring diagnostic and treatment outcomes in polysomnography and portable monitoring. And then the second one is sort of the VA. I was asked to speak about the Veterans Affairs approach to managing sleep apnea. So the first one is actually a little bit of a daunting title to prepare a presentation on, because when you talk about measuring diagnostic and treatment outcomes, I mean the types of outcomes that you could conceivably talk about, I think, are vast. And when you talk about polysomnography and portable monitoring, I mean, pretty soon you're really talking about the whole gamut of testing and identifying patients with sleep apnea. So I was a little bit uncertain as to how to go with this. But what I decided to do is to give kind of a talk, prepare a talk that really starts at, sort of breaks these terms down into very basic definitions about measurement and outcomes and what are outcomes, what is measurement, what do we measure when we talk about outcomes. And so as you'll see as we go along, I'll sort of talk almost on a philosophical basis about this. And hopefully this will resonate with you, those of you who have some sort of managerial role where you have to think about what you want to measure, because everybody where you work is keen on what are your outcomes. So I'm hoping to give you at least my view at starting at the lowest level and sort of working up to what are really the few practical outcomes that you can measure in sleep apnea. And then I'll conclude this presentation with a description of a research study that I was involved in that is just being published probably next month about outcomes in randomized control of home sleep apnea testing or portable monitoring versus the traditional laboratory approach. So I have disclosures to give. I've done work with a variety of different companies in this field at Respironics, ResMed, Embla. I've done work with Guidant or Boston Scientific in a somewhat different area, and now Vapotherm in a somewhat different area. I've also had some federal support for research, and I've been a consultant primarily lately to Itamar and Embla. So I'll talk about measurement possibilities, outcomes in polysomnography, outcomes in portable monitoring, or the term that I like, just like Dr. Goldberg likes, limited channel testing. The term I like is HSAT, home sleep apnea testing, because I think that is very descriptive of what we're talking about. Okay, so let's talk about measurement, which is the first word in my presentation. There is objective measurement, and there is sort of less objective or subjective measurement. And if you're talking about objective measurement, then it implies that you are quantifying something. In other words, objective means it's not subjective. In other words, there's a hard measurement. And usually it means that something is referenced to an external standard. I won't call it a gold standard because I think that brings up all kinds of associations which are not necessarily true in our field about certain things being the gold standard. But there are some things that are reference standards, which is a better term. It usually means you're using a tool. You're using something to measure what you're interested in. In other words, you're not just sort of looking at it and saying, I think this is X. You're using a tool to measure this thing that you're interested in, quote unquote, more objectively. It sounds scientific, so that sounds good. It seems like you should get paid for measuring something objectively instead of just making a wild guess about something. So objectivity sounds like it should get you more money. It sounds like it also is important and it has meaning. You know, if you say this is objectively, I have determined this is that, then that's what it is. And it's better to measure things than not to measure them. So if you're going to be in this field and you're asked to report on what you do, then you need to be able to measure something. Okay, so that's objective. Well, what about on the other hand, the subjective measurement? Well, it seems kind of less desirable. I mean, if you're talking about something important like sleep apnea management, you want objective measurement, right? I mean, you don't want something that seems kind of squishy. Subjective means less precise. You know, sort of my subjective gut feeling says this. It seems like it could be misleading. You know, you're subject to bias, and maybe your subjectivity about something gets in the way of being more objective. So it seems like something that's sort of risky about it, and maybe you should be careful about it. Okay. 50-year-old man tells you he snores loudly, falls asleep every night watching TV, and at red lights while driving, and he weighs 250 pounds. He fills out some questionnaire you have about sleepiness and says, on this questionnaire, I am 10 out of 10 on a sleepiness scale. You conclude he has sleep apnea. Seems reasonable to me. You examine a 50-year-old man. His oral cavity is small on the basis of intermolar distance measured with calipers, very precise measurement. His tongue has ridging. You can see the ridging. His soft palate just completely fills up the back of his oral cavity. You can see that. You can take a picture of it. His neck circumference is 50 centimeters, which is enormous. You conclude he has sleep apnea. Which measurement scenario of these two is more subjective? Which is more objective? Which one do you trust more? Who trusts the first one more? Who trusts the second one more? Well, let's talk about measurement in sleep labs, since that's where we're talking about working. There are things that you can objectively measure in sleep labs. You can objectively measure things like sleep stages. We know what a stage 2 epic of sleep looks like, stage 3, etc., REM. You can measure apneas and hypopneas. We know the definitions. We know what they look like on a test. You can measure oxygenation. You can measure body position, eye movements, body movement, vital signs. On the subjective side, you can measure snoring. There is no objective measurement of snoring. Snoring is very much in the ear of the beholder. You can measure the perceived sleepiness of the patient. Does the person look sleepy? Does the patient nod off while you're putting the electrodes on? You can measure, or you can get a sense of the level of anxiety of the patient. Patients sometimes come in and they look anxious, nervous, tense. You can get a sense of the readiness to accept therapy for, say, sleep apnea. You can talk to them about what the therapy options are, and you can actually get a sense from the way they ask you questions and interact with you what their readiness or willingness to accept a therapy might be. And we call that self-efficacy. You can check for nasal congestion subjectively, just the way they sound when they talk. You can subjectively look at their face and say, I think you have a deviated nasal septum because your nose is bent halfway over in your face. So there are lots of things that you can measure objectively, which have some importance. But I would argue that subjective measurement is just as important. And the things are different, but they each have value.